Thank you for the speakers that have travelled quite a long distance to be here today. We're going to start with Dr. Robert Bransfield.
Hi, I'm Dr. Robert Bransfield, an American psychiatrist from New Jersey, and thank you for inviting me to talk to the Welsh Parliament today. I'm sorry I can't be here. I have Welsh background dating back to Owain Gruffudd, who was King of Gwynedd in the 12th century, and his descendant, Dr. Thomas Wynne, who was William Penn's personal physician and a politician who helped establish Pennsylvania in the 17th century. I specialize in treating psychiatric patients who are treatment resistant, and this has resulted in my working with thousands of patients with Lyme and associated diseases over the past 30 years. In combining clinical experience with a broad spectrum of research, it becomes increasingly clear that injury from infections, including particularly tick-borne infections, cause a significant number of chronic conditions that impair, disable, and kill a large number of people. This is a major paradigm shift in medicine and gives us an opportunity to more effectively prevent and treat many conditions that were previously had much less treatment options. The Lyme disease spirochete has been found in ticks in amber that was 15 million years old. It's the most complex bacteria known and has great adaptive capability. We cannot apply the rules for other bacteria to Lyme disease. In addition, there are many other tick-borne co-infections and an activation of other latent opportunistic infections which cause complex interactive infections. The problem I have seen and written about in peer-reviewed medical journals include persistence of infection, addressing how Lyme bacteria causes immune and metabolic effects that result in a spectrum of neuropsychiatric symptoms that may include developmental disorders, autism, schizoaffective disorders, bipolar disorders, depression, anxiety disorders, eating disorders, sleep disorders, addictive disorders, cognitive impairments, dementia, seizures, suicide, violence, and other impairments. Common general medical symptoms include fatigue, musculoskeletal pain, headaches, nerve pain, as well as gastrointestinal, genitourinary, and cardiac symptoms. Many Lyme patients are given other diagnoses and are told their impairments cannot be cured and can only be managed. These diagnoses include multiple sclerosis, motor neuron disease, myalgic encephalomyelitis, chronic fatigue syndrome, bodily distress syndrome, and a number of mental illnesses. And these diagnostic errors obstruct access to more effective treatment. Many fatalities, both recognized and unrecognized, may be associated with suicides, drug overdoses, homicides, accidents from cognitive impairments, and multiple neurological and general medical impairments. Some of the individuals who started their research on tick-borne disease in the 1970s made major conceptual errors, looking at this problem from a very narrow and limited perspective. And these errors have been perpetuated in an extremely narrow disease definition. Rather than moving forward, many of these errors have been dogmatically defended in spite of overwhelming clinical and scientific evidence to the contrary. We are learning ecological disruption can foster the proliferation of ticks and the parasites which they transfer from many wild animals into humans can cause complex interactive infections, and these pathogens can survive in us by evading and disabling the immune system and causing multiple pathology in the process. The chronic immune effects from these infections can then impair physical, cognitive, emotional functioning and can cause general medical illnesses, mental illnesses, and behavioral problems. To make forward progress with this epidemic, we created the International Lyme and Associated Diseases Society, ILADS, and we have meetings in North America and Europe. We wrote clinical guidelines recognizing the significance of clinical judgment in 2003 and again in 2014, following the scientifically sound GRADE approach, which is the standard for healthcare guidelines. We are dealing here with a very complex problem. There are more facets to this epidemic than there are in the crown jewels, and no one is an expert in all the facets of this epidemic. Improved awareness of this association provides new opportunities for prevention and treatment that were previously overlooked. This is not just a problem for ecologists, entomologists, veterinarians, microbiologists, infectious disease doctors, immunologists, psychoimmunologists, psychiatrists, general medical physicians, patients, or governmental policymakers. It is a problem for all of us, and we need cooperative effort from all of us. Forward progress in the understanding of Lyme and associated diseases and access to adequate care have been very slow for decades. It has been stalled by silo mentality, a failure of creativity, adherence to flawed guidelines, and special interest. This epidemic gives us a choice and an opportunity. One choice is for a group of us who normally don't work together to be a team to solve a very complex problem that harms humanity and to help advance science and medicine and improve the quality of life for many. The other choice is to maintain the status quo and blindly follow outdated beliefs. As government officials, you are in a unique position to help science and medicine move forward by establishing policies that improve prevention, clinically relevant research, access to effective care, and accurate education of health care workers and the public. Full consensus and supporting evidence in science are rare, and competing views are the rule rather than the exception. There is a major controversy surrounding Lyme disease. One view is the narrow definition that conceptualizes Lyme as having reliable immune-based testing. It is a laboratory rather than a clinical diagnosis. The symptoms are not very severe and can be called just the aches and pains of daily living. Chronic infections do not exist. Co-infections are mostly insignificant and is easily treated with short courses of antibiotics. The broader definition recognizes the commonly used immune-based tests are highly flawed. The overall clinical assessment is critical in making the diagnosis. There is a broad spectrum of symptoms that can be quite severe. Chronic Lyme, it does exist. It is complicated by multiple co-infections, and some patients require extensive courses of antibiotic treatment. The total clinical exam is a cornerstone in medicine. The diagnosis is not just based on a flawed lab test, and every patient's treatment must be individualized. This is the approach in treating every other disease. Why should Lyme disease be an exception to a concept in medicine that has existed since Hippocrates? Based upon several studies, there is a very broad spectrum of symptoms that can be quite severe. A U.S. National Institute of Health study found that patients had high level of functional disability compared to what you would see with congestive heart failure and pain comparable to what you might expect coming out of surgery and fatigue comparable to patients with multiple sclerosis. The most disabling symptoms are fatigue, pain, cognitive impairments, psychiatric symptoms, and sleep disorders. Unfortunately, many who write infectious disease guidelines have very little competency in properly assessing these symptoms. In regard to persistent infections, on the internet I compiled 700 peer-reviewed articles demonstrating proof that persistent infection frequently occurs. This is well demonstrated with animal studies, autopsy, case reports, and review articles. A U.S. CDC study found the majority of Lyme disease patients are being treated with antibiotics for longer periods of time than are advocated by the IDSA guidelines, and only 39% of Lyme patients are being treated with short courses of antibiotics of 4 weeks or less. In addition, a recent study of 3,900 patients has proven there's a group of chronic Lyme patients that clearly benefit from longer courses of antibiotic treatment. Since there are conflicting opinions, research, and guidelines surrounding tick-borne disease, none are authoritative. The standard assessment in medicine is to perform an adequate exam that is relevant to the patient's complaints. We treat patients, not diseases. Laboratory findings have different degrees of reliability and should never be the sole diagnostic criteria, and Lyme disease should be no exception to this. Rarely is a diagnosis black and white. Individualized assessment and individualized treatment are always necessary. Evidence-based medicine is a combination of the best evidence available, clinical judgment, and patient preferences, all of which have limitations. Since the evidence surrounding Lyme and tick-borne disease is conflicting and unsettled, it is dangerous to impose rigid third-party diagnostic and treatment criteria. The standard of care is established by physicians who have the long-term responsibility for treating a disease, not by physicians who deny the significance of a disease. There is a very major distinction between standards of care and guidelines. Unlike the standard of care, guidelines are only suggestions for assistance with clinical decision-making. Unfortunately, a number of Lyme disease guidelines are established by epidemiologists, bench scientists, and researchers with an inadequate understanding of all the facets of the disease and without input from clinicians who have the long-term responsibility for treating these patients. Studies have shown the most significant and disabling symptoms from tick-borne diseases are fatigue, sleep impairments, pain, depression, cognitive impairments, anxiety, and irritability. Many who view themselves as Lyme disease experts and write guidelines which may be imposed upon others have no or very little experience regarding these symptoms. When what begins as an infectious disease and is inadequately diagnosed or treated can later become a psychiatric illness. The American Psychiatric Association assessment guidelines recognize the need to consider Lyme disease in the etiology of psychiatric illness, and the ILADS and German guidelines recognize longer courses of antibiotic treatment are needed for some patients. The IDSA guidelines include a disclaimer recognizing the need for individualized clinical judgment. These outdated guidelines from 2006 have had multiple criticisms and challenges since the day when they were published. They are highly biased, lack objectivity, and a large percent of the reference in the guidelines consist of the authors quoting their own work. Lyme and associated tick-borne diseases are treated by physicians from all specialties, and no medical specialty can call themselves the sole authority. Most late-stage disease is treated by physicians who recognize the broader definition of Lyme and are more inclined to follow the ILADS approach. Since the standard of care is determined by physicians who actually treat a given disease, the standard of care in late-stage Lyme disease most closely approximates the approach used by physicians who use the broader definition and the ILADS guidelines. The IDSA guidelines and other guidelines which copy them fail to adequately address the most significant late-stage symptoms, which include fatigue, cognitive impairments, psychiatric manifestations, and pain. If an inadequate clinical exam is performed, it can result in erroneously viewing the symptoms as having a psychiatric origin, and the patient is improperly labeled as having medically unexplained symptoms or bodily distress syndrome. Some quotes relevant to standards from the 2018 Tick-Borne Disease Working Group report submitted to the U.S. Congress include, thousands of articles show the association between infections and neuropsychiatric manifestation of illness. At least 400 articles support the association between tick-borne disease and neuropsychiatric disorders, which include but are not limited to depression, anxiety, bipolar disorder, cognitive impairments, and psychosis. When more than one set of guidelines exists, the question then becomes, who decides the appropriate course of treatment for the patient? Under the medical ethics principle of autonomy, the treatment decision belongs to the patient in consultation with his or her provider. As policyholders, you can play a critical role here to move forward science and medicine by developing policies that support individualized treatment, accurate physician education, clinically relevant research, and the recognition of the dangers associated with improper reliance upon flawed testing, inadequate diagnosis, inadequate treatment, and unfounded confidence in the deficient NICE guidelines. Please seize this opportunity to help us, to help our family members, your constituents, and our patients. Thank you.
Okay. Just to explain, obviously this is pre-recorded, but Bob Bransfield actually joining us via Skype. So you want to say hi, Bob?
Hi everybody.
Okay. Yeah, I'd like to hand over to Michael Cook, who's come up from Christchurch, driven up today, and he's going to be talking about the reliability of the testing.
Good afternoon. Thank you very much for attending. I think I might sit down because my memory. I have Lyme disease and my memory's so bad I can't remember what I wrote this morning. My background is in research and development in the computer chip industry, and retired on the south coast of England near New Forest, and was bitten by a tick and maybe many times, and eventually had a clinical diagnosis of Lyme disease in 2009. And since that day I've been carrying out research on Lyme disease and associated tick-borne diseases, and have published 4 papers so far in medical publications, and presented in a number of conferences. Lyme disease, maybe better called Lyme borreliosis, in the late stage neuroborreliosis, is an infection carried by mammals, birds, reptiles, and is transmitted to human beings by ticks. In the UK, the main hosts are mice and voles, squirrels, rabbits, foxes, sheep, deer, dogs, cats, etc. There are over 20 tick species in the UK, and human infections is mainly caused by Ixodes ricinus sheep tick, and there are some reports of Ixodes hexagonus, the hedgehog tick. There are more than 50 species of Borrelia. 29 have been put in the relapsing fever group, and 21 in the Lyme disease group, with 11 proven to be pathogenic. In the UK, 6% of the ticks are infected with Borrelia guerini, and 30% with Borrelia wallesiana. The Wallesiana is not a species that is targeted by the test kits that are manufactured. This is a photograph of ticks. They're very tiny in the larval mode, and even the nymphal mode, they're very, very small. There's an attached tick there, buried in a child's head inside within the hair. And one tick, a female tick, can lay up to 2,000 eggs for the next season. The risk factors are related to the location. It requires high humidity for ticks to survive. Woodlands, gardens, walking a dog, camping, they're all risk factors. This is one patient's 47 symptoms, or some of the 47 of the many symptoms. General symptoms are fatigue, weariness, dizziness, lack of temperature control, nausea. Excuse me. They're described as flu-like, but I've never considered myself. I've had flu many times, and Lyme disease is totally unlike flu, I can assure you. But it affects the eyes. You have floaters. You have partial blindness sometimes. Is that Bob coming through? You have hearing problems, tinnitus and partial deafness, musculoskeletal problems, arthritic knees and so forth, chest pain, neck pain, neurological problems, pins and needles, peripheral neuropathies, pins and needles, and clumsiness, balance problems, cognitive function problems, short-term memory problems, speech problems, and so forth. Fortunately, I seem to be doing pretty well today, but sometimes I struggle to get the right word. Diagnosis in England with the latest NICE guidelines requires testing. So the first thing will be, the first hurdle that the patient has to overcome is to achieve a clinical diagnosis. The symptoms are so vague, it's so multisystemic, that very frequently be considered something else. Bob described many of the conditions that are referred to. The second hurdle is a first tier ELISA test. That must be positive, and if that is positive, then it will go for a second test, a Western blot test. And if that is positive, then sometimes the disease is called positive. However, Some of the laboratories do consider an IgM response to be active infection, and an IgG response, antibody response, to be not active infection. The test kit manufacturers do not make that differentiation. For neuroborreliosis diagnosis, you then have to overcome a fourth hurdle, which is the intrathecal test, where the testing will demonstrate a higher level of antibody response in cerebrospinal fluid than in serum. In Wales and in certain cases in England, where the tests don't go to the reference laboratory, then there's an additional hurdle, because there'll be the clinical diagnosis, the first stage ELISA test in one of maybe your local laboratories. The sample, if possible, will then go to Porton Down, and then it will have a first tier C6 ELISA test, which I'll mention again in a short while. Then again another hurdle, the Western blot, and a fifth hurdle for diagnosis of neuroborreliosis. This shows a test algorithm with a two-tier Lyme test, where you have a positive ELISA test followed by a positive Western blot. Up until a few years ago, HIV testing using the rapid tests used in doctors' clinics would have a two-stage test, not two-tier test, two-stage. If the first test was negative, a second test would be done just to make sure that the first test was done correctly. The reliability, the sensitivity and specificity of the HIV tests now are so good that on those rapid tests that they actually have abandoned the second test. The sensitivity, independent researchers have published a lot of data on the sensitivity and specificity of tests, and that's in one of my papers, analysis of all this data. The wholesale ELISA test had from all the studies on all the tests for all stages of disease, had a sensitivity of about 62%. The C6 test is a synthetic peptide. It's not a native antigen. It's a synthetically produced thing that was targeted in America to pick up a number of different species, and is considered to be able to detect many species. However, I won't show it here, but in one of my papers it demonstrates this sensitivity varies significantly between species, and is not designed to detect. There's no data published for example, the Valesiana species. The two-tier test is about 54%, and an average of all those tests is about 60%. However, all of these samples that were tested by these independent researchers were samples from patients who were 100% positive for Lyme disease. They had either an EM rash or already a prior seropositive test. So this is best case. If you have patients who are immunosuppressed or early stage, the sensitivity is much less than that. Just to conclude, there are other problems apart from testing. The official data seriously underestimates the incidence of the disease. The Public Health England test laboratories are finding between 1,000 and 1,500 cases per year, but they think that it's higher than that. I'm suggesting that it could be between 30 and 70 times higher than the official numbers that are recorded, and that's has occurred in America. They used to consider the Centers for Disease Control said there were about 30,000 cases a year. In 2011, they lifted that from 30,000 to 300,000. That was in 2011. Now in the US, it's probably closer to 600,000 people a year getting Lyme disease. And in Germany, about 700,000 people per year being infected and diagnosed with the disease. In the UK, most cases of Lyme disease are undiagnosed or misdiagnosed as Alzheimer's, ME, chronic fatigue syndrome, arthritis, etc. The commercial test kit sensitivity is poor, as I've mentioned there, and the two-tier test can generate up to 500 times more false negative results than HIV testing, ELISA testing. The UK laboratory practice at one facility was proven to be flawed. I won't go into details on that, but the procedures were not, they did not follow the test kit manufacturer's procedures. The test kits do not target the major UK Borrelia species, and the sensitivity is totally unknown for many of those 11 species that are pathogenic, known to be pathogenic. Others may be pathogenic as well, just no data there. Doctors that have used antibiotic treatments as recommended by the International Lyme Associated Disease Group, which are longer than the treatment duration recommended by mice, for example, have been targeted for disciplinary action, while doctors using similar or even longer protocols for acne, TB, and so forth are not. And just as a note, specifically for here, who is checking to determine if the samples sent from Wales to England are tested within 5 days, within 5 days of blood draw, and maintained under refrigerated conditions for all those 5 days? That is a requirement from the test kit manufacturers. That's where I'll finish.
Thanks, Michael. And I'll just get the slides up for Jenna to present. Jenna's come all the way from Florida, is that right? Florida, and she's had quite a difficult journey to get here. And she's had to stay in seedy hotels, and I'm sure she'll be able to tell you all about that.
Well, we had a snowstorm when I was leaving, so 11-hour delay, and then everything was canceled, and then I was in a hotel, and the doors didn't lock, so I didn't sleep, you know, and then flying through the night, but here I am, so.
Okay, that should be it for them.
Thank you. So just to give you a little bit of background about myself, I'm a former senior advisor to the United Nations and also to the U.S. government, and my area of expertise has been services to the most marginalized groups. So I've worked globally, 42 different countries, basically helping bring services of education, healthcare, economic opportunity, you know, basic services. And I then found myself to be a member of one of the largest marginalized groups of patients when I found out at the age of 52 that my multiple decades of illness was caused by tick-borne diseases, and I recovered from what I'd been told I had multiple sclerosis, lupus, and 4 different autoimmune diseases. And after multiple months of antibiotics, my immune system was able to take over, and here I am today. So I'm in what you call remission, and here to work with you. So a couple of years ago, I had regained my health sufficiently to do some of my professional work, but apply to the field of Lyme disease. I wanted to see what I could do to help patients access care, because I knew there were many obstacles. And so I organized an international committee made up of scientists and doctors from multiple countries. They represent all regions of the world, relapsing fever borreliosis as well as Lyme borreliosis, and human rights people, lawyers, patients, etc. And we basically went to the UN system, and our overall goal was to change the ICD code so that Lyme had better representation, and so that these codes would then result in people not only getting a diagnostic code, but also they would get a reimbursement for treatment, and that the multiple complications from this illness could be recognized and tracked by various governments. So the International Classification of Diseases codes are developed by the World Health Organization, but the World Health Organization has 193 countries as members. So this means that public health representatives from every country in the world, with the exception of 2, have been part of a multi-year process to develop ICD codes. And we've had multiple generations of ICD codes. Typically they're done about every 10 years. We're now moving from a transition of ICD-10 to ICD-11. If you have good, accurate codes, you can, have good, solid medical and public health guidance, research policy. You can save on healthcare expenses because you can anticipate what is happening with certain populations and how the response should be made. Now, the codes for Lyme disease or Lyme borreliosis, as we call it, have not been changed since the 1990s. So for 25 years, they remained stagnant. And the last time the World Health Organization had a committee to look at Lyme borreliosis was 25 years ago, in 1994. So it's been stagnant in the World Health Organization. So, just so you know that there are many different types of codes, and as you can see, some of them are quite interesting. There are a lot of codes related to injury because insurance companies like to have liability reduction. So, there's also a code that in case you get, struck by a spaceship, your insurance company will be reimbursed. Here's another code. Lady Gaga and I put that request in for the bizarre personal experience with her, and so. Anyway, what I want to say is that the code process, even though it's supposed to be identifying scientific and medical data to better create awareness and tracking and healthcare response and policy response, in fact, it's a highly politicized process. It's very politicized because this always means money. Who's going to get covered? Who's not going to get covered? How will costs be shared? Who will benefit from these diseases being recognized? To give you an example, we did not have a code for Ebola until 2016. Why do you think we got an ICD code for Ebola in 2016? Because it became a threat to Europe and the United States. Ebola was discovered in the 70s, but as long as it was a disease that was kind of impacting poor nations without much, concern, it did not have a specific code. When it became a threat to Europe and the United States, there was a big rush to try to have some kind of response for perhaps a global pandemic of Ebola. And so they assigned a code, and with that code comes all the information on the symptoms and the possible treatments, etc. So it's a very important process. Anyway, so right now, basically what we did was we made the case to the World Health Organization that the current codes were actually preventing proper diagnosis and treatment and preventing care. And even though everyone has ratified health human rights, many Lyme patients and tick-borne disease patients are desperately marginalized and suffer gross human rights abuse at the hands of state actors. And this means basically policies for Lyme, because they're generated by state actors, are generating human rights abuse. And what we found, we did a very detailed analysis, turned in 2 major reports to the United Nations, whereby we detailed 14 human rights violations across 11 different international treaties. And these reports were accepted by 2 different special rapporteurs and put into record at the United Nations. One of the interesting things is at the time we were starting this process, the Special Rapporteur for Health Human Rights gave a presentation to the General Assembly of the United Nations and said that out of all the sectors globally, whether extractive industries or tourism or logging or manufacturing, the sector that had the most corruption globally is the healthcare sector. And it is really actually considered a threat to national security in some places because it's becoming such an overwhelming cost. And it is overrun with corruption. So specifically, if we look at the the guidelines for the Infectious Disease Society of America, which was produced in 2006, between the 1990s and 2007, the persons who wrote these guidelines and their affiliates accumulated over 202 patents. And yet when they did the guidelines process, they only reviewed 20. So there's a huge amount of conflicts of interest behind this in terms of how the disease was defined and presented. To give an example, one of the guidelines authors, his name is Raymond Gottweiler, who's done a lot of work. He put out a patent immediately following the IDSA guidelines that completely contradicted what the guidelines said. The guidelines said that this disease is easily diagnosed, easily treated, and easily cured, and yet you can see the language in his patent says that it is hard to diagnose, it doesn't clear easy, it often needs multiple different types of antibiotics, and there's actually an overall lack of effective diagnostic tools. So the guidelines he had just produced stand in complete contrast to the patent he was putting out in 2007. So basically we made the case that the current ICD codes for ICD-10, instead of creating and generating better care, were an embedded obstacle globally, because these codes are adopted globally, and so they were actually embedded obstacle care across the globe. And here's a list of the many human rights treaties where we found violations. And as you can see, it's quite comprehensive. And here is a list of the 14 human rights violations. Every one of them, I have tables upon tables upon tables citing the specific articles as well as specific examples from multiple countries where these violations are taking place and how these violations are taking place. So the right to health, right to life, right to freedom from torture and cruel, inhumane, and degrading treatment. If you'll see, patients are offered euthanasia and sick children are seized from their homes. These are gross human rights violations. This is happening actually in Scandinavian countries and in Holland, whereby if a patient fails to, their health fails to improve after a short course of antibiotics and they continue to suffer and they go to seek more care, they are told they can be offered euthanasia. And this has been documented multiple times in multiple countries. We also have many countries whereby there's a private organization responsible for helping with child protection services, and they get a fee for each child they remove from the home, and so they have an incentive to remove children from their home, and a large percentage of the children removed are those with Lyme getting extended treatment and missing school. Public policy is often empty theater. People are asked to participate, stakeholders are brought in, but they've already determined the outcome, and there's really no negotiation or discussion. But it looks okay. I have a cartoonist that I work with because these topics are very heavy, you know, and at the same time, these organizations and groups that things we're trying to change are very powerful. So I have found that humor and satire can be quite effective. Right to bodily integrity, right to liberty, security of person, right to privacy and confidentiality. In many countries and in many parts of the United States, when somebody gets a Lyme diagnosis, that information is shared with other institutions against our HIPAA rights, and also in different countries. And it's actually affecting people's access to jobs and people's access to educational opportunities. And it's being shared without their consent. Now, why would you be sharing information about a disease that's so minor? All you need is a couple weeks of antibiotics. The state fails to provide information regarding the risk of disability and death from undiagnosed and untreated Lyme. One of the reports we turned into the UN was about the situation of human rights defenders. That means the doctors who treat, the scientists who are trying to determine things, and the parents who are trying to protect their children. These are all considered human rights defenders, who put in a very detailed report to the Special Rapporteur for the situation on human rights defenders, And now all of these categories of people are recognized formally as human rights defenders by the UN. So people who are treating Lyme, people who are doing the scientific research, and the parents who are trying to protect their children's health and get them adequate care. And this group, if you look at this from a really financial situation, really what's happening in many cases is competing market shares. Who's going to get the most patients for what money, and going after the groups that are competing with them. And particularly in the United States, what people do not know is that in the U.S. in the 1980s, the law was changed so that U.S. government officials can have a patent while they're in office doing public service with a private sector enterprise. And they can actually generate and get royalties from their patents. And they can then sit on a committee where a competing technology will come forward and they will dismiss that technology even though it's better than theirs, because they have the authority as a government official and they are getting incentives and royalties from their patents. And it's really corrupting a lot of science and medicine that then gets exported globally. And it's such an issue. When I was in Geneva, I met with senior officials from the World Intellectual Property Organization, and they wouldn't even meet me formally in the office. We had to go meet around the corner, and they said this is driving a lot of issues globally in terms of science and technology and integrity of science and technology. So I don't know if some of you have heard, there's a fairly well-known French doctor by the name of Christian Perron, and he's in charge. He's been in charge of like every possible committee in France and in charge of the national academies and educational things. And he's a consultant to the World Health Organization, and he sat on the Global Committee for Vaccines, and he's very highly credible and well-respected. Hundreds of publications. And he gave a presentation on Lyme to the National Academies of Medicine there in Paris, and the president called him a terrorist. So this is how heated it is in terms of, because there's so much money involved with this epidemic. And there's a lot of grants and a lot of patents and a lot of positioning also around therapies and treatments. So our report to the United Nations, the first report, put in the request for all of these various complications to be recognized under the ICD codes. And we gave no less than 3 peer-reviewed publications from very validated journals to augment this. And this was all entered into a very public, anyone could access a beta digital platform where anybody in the world could go and review this and see that these publications had been entered, as well as the request for all of these complications to be recognized. And we were fairly successful. So in June 2018, the draft came out. It's going to be validated in May 2019. And Lyme in the ICD-11 does not resemble an infection that is easy to diagnose, treat, and cure. So here is the new global face of Lyme. And you can see there is a significant difference. And some of the most significant differences is that we now have 5 life-threatening complications that have been recognized. We now recognize congenital Lyme. We now recognize that Lyme causes dementia and a series of demyelinating conditions. And this list shows many different complications that are later stage, which indicate that when people get treated early and they go on to develop these very serious complications, there's clear treatment failure. And it also indicates that the diagnostics are not catching a lot of the cases. So it really reveals a lot of the flaws in the current practices in terms of diagnosis and treatment for this illness. And this young lady was hoping we could just go back to the 3 earlier symptoms. So we had a 400% increase of codes. And 14 of the 15 new codes can be applied to late stage and chronic forms of the illness. And what's very interesting is many of these new codes show that this disease prefers the central nervous system, and that's where so much of the damage takes place. We can no longer characterize this illness as arthritic knee, when in fact it's doing so much damage, severe damage to the central nervous system. And what's important is, though, even though these codes are not going to be formally adopted until 2019, and countries have until 2022 to integrate them in their institutions, the fact is that all of the science has been validated as of June 2018. So all of these publications that for years have been disputed or dismissed by various medical societies or, different institutions have now been validated by the World Health Organization. And the World Health Organization is the only multi-governmental, multi-stakeholder public health institution in the world. And they have a very, very strict process in terms of transparency and accountability for all these peer-reviewed publications. So to give you an example, many countries, they said, we're not going to consider all of the primary research on congenital Lyme because it was done 15 years ago. It's out of date. Well, there's been no primary research on Lyme since then. And so the World Health Organization says we have to take the primary research and consider it. And because that's where we found all the data, they adopted the code. So a lot of the cherry picking and the politicizing and the moving, maneuvering around this, the World Health Organization was able to kind of clear through with very strict standards on scientific requirements for review, literature review. So here's just an example. All of these, almost every one of these publications that was validated by the World Health Organization was thrown out by the NICE Guideline Committee. So that's important to know. Now, the other thing that's interesting is that even though we didn't get every complication that we wanted recognized, the new codes have what we call descriptor codes that can be added to the codes that are listed. So, for example, we don't have a code for hepatitis caused by Lyme borreliosis, even though we know that's the case, and there's multiple peer-reviewed journals showing that, these articles that show that's the case. But what we can do is we can take a generic code saying non-specific bacterial infection causing hepatitis and tie it directly to a code for Lyme. And so now we can get multiple complications that were not recognized. So here's a generic one. Other specified Lyme borreliosis. Then we take non-specified bacterial infection causing hepatitis, tie it to that one, and then you can get access to medical care. And I just wanted to say one of the things that was very important in terms of not being recognized by the World Health Organization is a term called post-treatment Lyme disease syndrome. And this is very important because in many countries this term is being used to deny medical care. It was introduced officially in the 2006 IDSA Lyme guidelines, and it was kind of an open-ended, what is causing these ongoing symptoms? And they kind of opened it up and let's look at it from a research perspective. But by 2008, 2 years later, the National Institute of Health and other medical societies had already come up with research that defined it as a psychosomatic illness, a form of hypochondria, and so people were denied any further treatment. And this has been, a corrupted, fraudulent practice to deny medical care on post-treatment Lyme disease syndrome. If you go through your 1 month of treatment, and then, 3 months later you're still complaining, you're now called a malingerer or a hypochondriac, and you're given antidepressants and told to get some counseling. And this is very important that they did not validate this syndrome. So, right now, these codes will have a pro forma vote will be taken, and then, as I said, it was up to 2022 in order to adopt them, but we can use the science that's been validated today in June to start changing policies. And let's consider for policies for prevention for Alzheimer's and dementia. That's a huge health costs that many countries are facing. Well, now that we know that Lyme can cause dementia, in fact, when somebody gets a diagnosis of Alzheimer's or dementia, there should be an empiric therapy provided to that person to determine whether or not it might not be an infectious agent causing dementia. And you can then overturn. It's not just necessarily Lyme. They've been finding many infectious agents causing dementia. But when we talk about in terms of prevention, so study after study is showing that actually many forms of these degenerative diseases have underlying infectious agents, not just Lyme. Lyme is one of them. Another one we can talk about in terms of prevention is because it's congenital, we can't just have it focused on ticks and prevention of tick bites. So if you are a woman planning to get pregnant or you are pregnant, you should be able to ask for a Lyme test to see if you might be carrying the infection to prevent passing it on to your unborn child. And if you have symptoms, and even if you test seronegative, you should be able to get empiric therapy to get a treatment in order to prevent that transmission to your child. So that's kind of really opening up the whole idea of how do we do prevention of this illness. It's not just tick to human, there's an intrahuman possibility, which is very, very critically important to understand. So, thank you very much.
Thank you.